So hello everyone, today's topic is on osteology of humerus. So humerus is an example of long bone located in the arm. So it is an arm bone. See the features of humerus. So we know humerus is a long bone. The upper end of the humerus, it has got 5 parts. This is a smooth round surface which articulates with the scapula to form shoulder joint. So here is the scapula. It articulates with the glenoid cavity of the scapula to form shoulder joint. So that is about the head, and there are 2 projections which are appreciated on the upper end. This large projection is the greater tubercle and small one is the lesser tubercle. And between the greater and lesser tubercle, the groove what we see is the intertubercular sulcus. This is the intertubercular sulcus, and humerus we can understand by 2 necks. One neck is the surgical neck of humerus. This is the surgical neck of humerus, which is a constricted part separating the whole upper end from the shaft. The next neck is the anatomical neck of the humerus. So along the smooth surface, if we draw a line separating from the greater and lesser tubercles, the rough part, this is the anatomical neck of the humerus. So anatomical neck and surgical neck of the humerus. So these are the 5 parts of the upper end. Let's see the parts of lower end of humerus. Lower end, it has got the capitulum. This rounded projection is the capitulum. So it is a lateral rounded convex projection, and medial to the capitulum is the trochlea. The pulley shaped structure is the trochlea, which is a pulley shaped structure, and medial to the trochlea, this medial prominent projection is the medial epicondyle of humerus, and lateral prominent projection is the lateral epicondyle of humerus. We can see the medial epicondyle is more prominent than the lateral epicondyle, and above the capitulum, this fossa is called as radial fossa because the head of the radius fits here during elbow flexion, and above the trochlea, this shallow depression is called as the coronoid fossa, where coronoid process of ulna fits into it. Posteriorly, this large halo above the trochlea is the olecranon fossa. This large halo is the olecranon fossa. So that is, these are the parts of the lower end of the humerus. Let's talk about the shaft. The shaft, we know it is a long part of the bone extending between the upper and the lower ends. And to understand the anatomical position of the humerus, this head should be facing medially. The head should, because it articulates with the glenoid cavity to form shoulder joint. So head should be facing medially. Lesser tubercle should be anterior side, and inferiorly we can see more prominent medial epicondyle on the medial side, capitulum on the lateral side, and trochlea on the medial side. So this is how we can determine the side. So what I am holding is the left humerus. So next about the neck. Neck, I already talked about the anatomical neck and surgical neck. There is one more neck called as morphological neck of humerus. It is the true junction between the head and the shaft. That it is almost in line with the surgical neck. It is the junction between the diaphysis and the epiphysis. It is represented by an epiphyseal line in the adult. So the epiphyseal line in the adult, it is not prominently seen in this bone, which separates the upper end from the lower end, which is almost in near with the surgical neck. So this is called as morphological neck of humerus. Surgical neck, we know it is related to axillary nerve and posterior and anterior circumflex humeral vessels. It is most important feature of the proximal end of the humerus because it is the weaker than the proximal regions of the bone. Hence, one of the sites where humerus commonly gets fractured is the surgical neck of the humerus, leading to the damage of axillary nerves and vessels associated with it. So that is about the importance of surgical neck. It is related to axillary nerve and it is related to circumflex humeral vessels. And one more thing I want to say about the anatomical neck. The anatomical neck, it is a constricted margin separating from the smooth part from the rest of the rough part in the upper end. This margin provides attachment to capsular ligament of shoulder joint. Attachments of muscles of each part, starting with the greater tubercle. So here is the greater tubercle which is present on the lateral aspect. So greater tubercle provides attachment to sit muscle, SIT, you can remember as a mnemonic. S stands for supraspinatus, then infraspinatus, teres minor. So three muscles are inserted to the greater tubercle. Next, about the lesser tubercle. Lesser tubercle is a small elevation which is present in front of the humerus here, just above the surgical neck. It provides attachment to subscapularis muscle. So subscapularis muscle is inserted to the lesser tubercle. Supraspinatus, infraspinatus, teres minor are inserted to the greater tubercle. Altogether we can say sits, SITS, sits muscles which form rotator cuff or musculotendinous cuff. Next, about the intertubercular sulcus. The groove between the greater and the lesser tubercle is the intertubercular sulcus. It is a vertical groove and it contains long head of biceps. So it contains a long head of biceps which is lodged in the groove and which is enclosed in a synovial sheath, and it is related to ascending branch of circumflex humeral artery as well. The three muscles which are attached to this groove are pectoralis major, teres major and latissimus dorsi. We can remember as lady between two majors. Pectoralis major is on the lateral lip of the groove. So the lateral lip, the outer side, the lateral lip of the groove is the pectoralis major. Medial lip is the teres major. In between, the floor of the groove provides attachment to latissimus dorsi muscle. So lady between two majors. So the floor provides attachment to latissimus dorsi. Pectoralis major is inserted on the lateral side. Teres major is inserted on the medial side. Let's see the upper part of the shaft. In cross section, the upper part of the shaft is rounded and lower part of the shaft in cross section it is triangular, where the apex is facing anterior side in lower part, whereas the upper part of the shaft it almost appears to be rounded and it is cylindrical. The anterior side, what are the muscles attached? So this rough area what we are seeing on the lateral anterior aspect, this rough part is called as the deltoid tuberosity, which is a rough area in front of the shaft almost in the middle of the humerus, and it provides insertion to deltoid muscle, which is a multipinnate muscle. So this rough area is called as deltoid tuberosity. This is called as deltoid tuberosity, which provides insertion to deltoid muscle. The rough strip in the middle of the medial border, the rough strip just opposite to the deltoid tubercle, this rough strip provides attachment to coracobrachialis muscle. So coracobrachialis muscle is inserted to the medial side of the shaft opposite to the deltoid tuberosity. And a narrow area above the medial condyle, medial epicondyle, this is the medial epicondyle, and provides origin to the pronator teres, just above to the medial epicondyle, origin of pronator teres is seen here. So pronator teres gains its origin above the medial epicondyle. Then medial supracondylar and lateral supracondylar ridges, the lines above these are the lateral supracondylar ridge, this is the medial supracondylar ridges, which provides attachment to intermuscular septa, which separates the anterior compartment from the posterior compartment. The whole of the anterior surface, lower part of the anterior surface below the deltoid tuberosity provides attachment to brachialis. The lower half of the humerus anteriorly below the deltoid tuberosity gives origin to brachialis muscle. Let's see the posterior side of the humerus. This is the posterior side. We can see the olecranon fossa here of the shaft. Upper 1/3 of the posterior surface, we can see an oblique ridge. We can see a beautiful oblique ridge we can see, and which is downwards and laterally, and the ridge provides origin to lateral head of triceps. So the ridge, this oblique ridge provides attachment to lateral head of triceps muscle. Triceps brachii muscle gains its origin, lateral head, from this oblique ridge. And below the medial ridge, below and medial to the ridge, the spiral groove is present along the oblique ridge. This oblique groove, this groove is called as the spiral groove, which is almost in the middle of the shaft of the humerus, where radial nerve and profunda brachii vessels are present in this spiral groove. The spiral groove is otherwise called as radial groove also. The entire posterior surface below the spiral groove, means this part, the entire posterior surface below the spiral groove provides attachment to medial head of triceps brachii muscle. So lateral head from the above the ridge and medial head below the ridge, and the spiral groove, the groove is present within which the radial nerve and profunda brachii vessels are present. And lower end, we can see it is flattened, and we know the capitulum, the rounded capitulum, which articulates with the head of the radius, and the trochlea, this trochlea, it articulates with the trochlear notch of ulna. And the medial epicondyle is quite important clinically, because posterior to the medial epicondyle, ulnar nerve is related. So ulnar nerve is present posterior to the medial epicondyle of humerus. Posterior to the medial epicondyle, ulnar nerve is present. So humerus means funny bone. It is funny bone because if the medial epicondyle is hit to the hard surface, usually we experience a kind of shocking kind of pain, that is because of ulnar nerve compression or trigger to the ulnar nerve. So that is the reason it is called funny bone. So posteriorly, the ulnar nerve is related on the medial epicondyle of humerus, and medial epicondyle is otherwise called as common flexor origin, because all the superficial flexors of the forearm gains their origin commonly from medial epicondyle of humerus, which is called common flexor origin. Lateral epicondyle provides an area called as common extensor origin, where the extensor muscles of the forearm gains its origin from common extensor origin. The posterior surface of the lateral epicondyle also gives attachment to anconeus. Let's see the nerves which are directly related to the humerus. So we know the axillary nerve related to the surgical neck of the humerus. Radial nerve is related to the radial groove or spiral groove of humerus, and ulnar nerve is related to the posterior side of medial epicondyle of humerus, the ulnar nerve. The most common clinical complication associated with the supracondylar fracture of the lower end of the humerus is myositis ossificans. Myositis ossificans is a clinical condition where the bone tissue forms inside the muscle and the other soft tissues around the elbow during the regrowth of the bone. During the regrowth, resulting a deformity, this myositis ossificans occurs. It is a common clinical condition. The cause is still unclear, but it occurs if we try to manipulate the elbow joint. If we try to manipulate the elbow joint, especially in supracondylar fractures of humerus, which results in myositis ossificans, where a bone tissue forms in the soft tissue, that is in the muscles, resulting a deformity. Next, about the ossification of humerus, it has got one primary center for the shaft of the humerus and 3 secondary centers for the upper end and 4 secondary centers for the lower end. So the upper end, the secondary centers are like for the head and for the greater tubercle and lesser tubercle. For head, it appears around first year after birth, and for greater tubercle 3rd year, for lesser tubercle 5th year. And the shaft, we know it has got a primary center. It appears during 8th week of intrauterine life. And the lower end, the secondary centers for the capitulum around the 2nd year and the lateral flange of the trochlea it involves, medial part of the trochlea, and the lateral epicondyle, and also the medial epicondyle has individual secondary centers. The upper end joins with the diaphysis by 20th year and lower end joins with the diaphysis by 16th to 17th year. So this completes the ossification and clinical aspects of humerus along with its osteology. Thank you.